Good afternoon, good evening. Welcome to today's Grand Rounds, Modern Surgical Family, Parental Leave in Training and Beyond. I am your moderator, Navpreet Dhillon, the Associate Member Education Committee Chair. So before we begin some logistics, please remember beginning in 2021, AAST will no longer offer CME for live Grand Rounds. Should CME be available for the archived version of this Grand Rounds, those who watch today's Grand Rounds will receive an email once the archived version is available on the AAST website to prompt you to log in and claim CME. Now, shifting gears, today's Grand Rounds is brought to you by the Associate Membership for the very first time. So it's a very special thing for our group, and we are extremely grateful for this opportunity. Now, over the past few months, there's been a lot of discussion nationally about some very few important topics. And as a group, we thought these topics were very relevant to the associate membership. These discussions have resulted in today's topic and upcoming discussion. Now, without further ado, our agenda will include defining the problem. We'll receive some updates from the American Board of Surgery by Dr. Buyske, a call to action by Dr. Dultz, and then we'll have a number of panelists who will describe their experience, followed by a Q&A session. Our speakers and panelists include Dr. Ryan Duma, who did his training over at Indiana University, residency at UT Southwestern, his fellowship at UPenn. He's currently an assistant professor of surgery at UT Southwestern, along as being the Associate Trauma Medical Director and Associate Program Director at UT Southwestern as well. He also is the AAST Associate Member Council Vice Chair. Dr. Chrissy Guidry did her medical degree at Des Moines University. She did her residency at Cleveland Clinic, her fellowship at LA County, USC, and is currently an assistant professor of surgery at Tulane. Dr. Linda Dultz did her medical degree at New York Medical College, residency at NYU, fellowship at Hopkins. She's currently an assistant professor of surgery at UT Southwestern, where she is the program director of the fellowship program and the medical director of the surgical intensive care unit. She is the secretary of the AAST Council. Dr. Buyske is a representative for the American Board of Surgery. She did her medical degree at Columbia University, residency at MGH, the adjunct professor at UPenn, and currently serves as the president and the CEO of the American Board of Surgery. Our panelists include Dr. Julia Coleman, who did her medical degree at University of Toledo, master's at Ohio State, residency at University of Colorado, and will shortly become a fellow at the Ohio State and is our associate member, Communication Social Media Committee Chair. Dr. Brittany Bankhead did her training at Ross University and the University of Texas at Austin. She did her fellowship at MGH, and she's an assistant professor at Texas Tech, and she serves as our communications and social media counselor. And then we have Dr. Matthew Strickland, who did his medical degree just above the border at Northern Ontario School of Medicine, residency at the University of Toronto. He did his fellowship at LA County, USC as an assistant professor at the University of Alberta, and is our treasurer. So without further ado, we will start our first presentation with Drs. Duma and Dr. Guidry.
Yeah, see this okay?
No, I can't see your slides.
Oh, sorry. Technical difficulties here, guys. This screen sharing has failed to start. Let me.
You want to send them over to Afia real quick?
Yeah, let me see here.
Or Navpreet or myself?
Let me try one more time. Not sure why, we just did a whole tech check. How about that?
Yeah, I hear it coming.
All right, I apologize, guys. Dr. Guidry.
You're showing in presenter mode. So
All right. Let's see here. We'll just do, sorry, I'd like this. Does that work there now? Still the wrong screen. Better?
yes.
All right.
All right, so let's get started. Thanks y'all for joining us this afternoon. So you may be thinking to yourself, why is this topic important to me? Some of you have children that are already grown. Some of you have grandchildren. Some of you have young children, or some of you are like myself, currently childless. This is the simple fact is that humanity must continue to flourish by reproducing. We must acknowledge this and be willing to support the process. Every practicing modern surgeon should not only want to be familiar with this data presented today, but also be socially competent and engaged in the discussion of family planning. In order to dive into parental leave, we must first address the barriers pregnant surgeons face even before delivery. Applying this knowledge will make you a better surgical partner and colleague, and ultimately lead to more efficient, team-driven delivery of superior patient care. I'd like to engage you in a scenario that was shared to me that happened to a female acute care surgeon. I want you to imagine yourself and how you would have reacted to this request. You're sitting at home, not on call. You get a call from a colleague and she's in the hospital. She recently found out she was pregnant and she's now experiencing nausea, vomiting, and severe dehydration, requiring hospitalization with IV resuscitation. Her doctor told her to avoid call for a week after discharge, which was going to require that she miss her scheduled call on Christmas Eve. She called all her partners and no one could cover her call. One partner even mentioned that Christmas Eve was still a few days away and that she'd probably be good by then. How would you have responded to this? Of note, her call was eventually covered, but not without a follow-up email to all the partners shaming her for the lack of coverage when she was out. Let's talk about some current barriers before we start even talking about parental leave. There are several barriers creating a negative impact in pregnancy in a female surgeon's life. Why is it that 62% of female surgeons have children compared to 92% of male surgeons? A recent contemporary review revealed that female surgical residents continue to voluntarily delay childbearing. The delay in childbearing appears to be influenced by surgical culture and the negative perceptions of female surgeons who become pregnant and have children during their residency training. The obstetric complications for female surgeons are alarmingly high and not fully understood in the current literature. Did you know that female surgeons suffer a pregnancy loss rate at 42%, which is more than twice that of women that are not surgeons? Currently, pregnant surgeons oftentimes delay their own self-care in fear that they may appear weak when compared to other non-pregnant colleagues. Here's a picture of one of my chief residents a couple of years ago who had complications during her third trimester. She was diagnosed with intrauterine growth restriction and needed to decrease her clinical workload during her chief year. I remembered the so much guilt she had during this time, but it was all worth it. And here's a little one. Let's chat about the physical barriers now. There are obvious technical barriers faced in the last trimester with pregnant surgeons. They have difficult time physically just reaching the operating room table for open bedside cases. Here's a dear friend of mine and colleague who was operating until the last week of her pregnancy. She said that she was just able to adjust her operating skills by turning sideways during the operation. As you can imagine, this is not ideal. And then let's talk about the financial barriers. Delaying pregnancy also comes with an increased financial burden to surgeons. When parental leave is not covered, an attending salary is much higher price to be without compared to a resident salary. We all know that. Not to mention, delayed maternal age when trying to conceive can lead to costly in vitro options that are mostly not covered by insurances. But let's think about what our surgical trainees think about.
So thanks, Dr. Guidry. It's a really, I think, great introduction. So what do the trainees think about? I like this study because I think it starts to lay the groundwork for the problematic surgical culture that Dr. Guidry has kind of described. In this survey of nearly 1,000 respondents, 2/3 of which were female, and nearly 50% of whom had been pregnant, the researchers found that 27% did not feel supported by their department during pregnancy. 20% found arranging leave difficult. And I thought, very interestingly, the most common source about information about leave was actually from other trainees and other people, and not necessarily the department. This is also a very interesting study, and that's actually published in the same year, but you'll notice a slight subtle difference. What I like about it is that the titles have changed. The prior study defined maternity and paternity leave, but this study really shows an evolution in the discussion, and we're revolved from talking about maternity and paternity as two separate entities to parental leave. So this study is, again, also a survey, but this one has over 2,000 respondents, and it's actually remarkably similar, the results that these investigators found. Almost an identical number of respondents as the prior study felt that they were not adequately supported by the department and also their co-residents, which I think really points to this being an issue of culture too. Interestingly too, there's also an awareness and a perception problem. Only 4% of the respondents were able to correctly identify the current, at that time, ABS leave policy. So what do? We take FMLA, right? But FMLA in its simplest form is simply job protected unpaid leave. But obviously for residents and fellows, that's not a practical solution because of the impact that this currently has on their training. And keep in mind, FMLA only applies if you work for a company of 50 or more. I like this graphic because I think they help show the landscape of current paid leave in the United States. So really, in the United States, we are one of 7 countries without a national paid maternity leave, right? So that's maternity. This is the paternity leave. Paternity leave is a little bit, as you would imagine, not as common across the world, but still, the United States is 1 out of 83 without a national paid paternity leave. Globally, the average maternity leave is 29 weeks, and the average paid paternity leave is 16 weeks. So what's the landscape like in the United States currently? It varies by state. There's 8 states and the District of Columbia that have paid leave and of some variation. Now, keep in mind, paid leave can be different. It's usually not your full salary, and it's usually funded by social infrastructure and insurances. And what's very interesting about these paid leaves, a lot of them are new. Most of them have been only enacted within the last few years. For example, California's new Parental Act was I think enacted in 2019, and the Connecticut Family Leave Medical Act is to be started January 1st, 2022. Our federal workers are afforded more paid vacation, and that's also recent. Only as of October 2020 do federal workers get paid leave. And if you've been paying attention to C-SPAN at all, and any of the national discourse that's currently going on as part of the Build Back Better Act in Congress that the House and the Senate are currently working through, this is the first, I think, attempt to develop a federal or a national plan for paid leave. There's obviously some cons already. The original bill, as it was proposed, was for 12 weeks, and that's been cut down to 4. Now, there is an important pro, which I think is important mentioning about this proposed bill, is that the leave is actually very broad. It also includes things like if you need to be out for surgery, for recovery, or if you need to be out to care for a loved one, for example, who's ill. But I think really importantly, which I hope we've kind of expressed to you over the last 10 minutes, that the landscape is changing. We're talking about parental leave now, and we're really focusing on a change in culture and increasing awareness, which is ultimately what this is really about. And what I hope what we're going to spend the next 40 minutes really talking about and expressing to you guys. And I love the stat, Dr. Guidry, when she sent me back the slides that we had gone back and forth to do, she added this, and I think this is really great. So 20 years ago, half dads weren't changing diapers, and hopefully my wife can attest that I'm a pretty aggressive diaper changer, and I think it's a really an important part of a lot of what we do. So with that, I'll turn it back over to you, Dr. Dhillon. Hopefully I can figure out how to stop sharing. I think it's easier than how to share.
Thank you, Dr. Duma and Dr. Guidry. We are exceptionally grateful to have Dr. Buyske from the American Board of Surgery, who will provide details regarding the ABS's recent policy change. Dr. Buyske.
I go ahead and share my screen. I have a little bit of a drier conversation since we're talking about policies, and I also don't have as good slides as all y'all do. But I want to talk about the role that the American Board of Surgery has in developing these policies and therefore impacting the amount of time that you have with family. And I want to start off by saying that I have exactly zero interest in counting weeks or counting cases, and that the real long-term solution to this will be competency-based advancement through training, which case I don't have to say, oh, did you only work for 44 weeks? Well, then you owe me 2. You have to work till July 14th. I can say, did you complete your portfolio of competencies? So that is coming, or we've been working on that for the last 5 years and plan to implement it for the entering class of 2023. But that's a pretty long gap before there's going to be a graduating class, which will be 2028 at the earliest. So in the meantime, we want to do what's right and fair and appropriate. So I work for the board. I always include our vision statement because it's to unify surgery in the pursuit of excellence in patient care. And it's really supposed to mean that board certification and the standards that we set are so apparent to all surgeons of high value, that so apparently of high value that everybody stands behind them. But I'd also say that unifying surgery means being inclusive, including everybody in all their different aspects of life and all the ways that they come to surgery. And I'm not a person who likes to have doors slammed behind people. When I started at the board in 2008, if you stepped out of surgery for any significant period of time because you had a car accident, because you had a depression, because you had a baby, there was no getting back in. So we've spent the intervening 12 years trying to make sure that there are on-ramps and that we minimize the likelihood that people are going to leave surgery through a variety of ways. Give some other entire talk about that in the future. And then the mission statement, and I'll draw your attention really to the end, is the highest standards for professionalism. And professionalism to me means taking care of your colleagues. And if they need to be on bed rest on Christmas Eve, you might need to cover for them, and just figure that what goes around comes around at some point in time. But I also would point out that the very beginning of the mission statement talks about serving the public, and the public comes first with a very close second of enhancing the profession. So we walk this tight line, which all of you do every single day. Historically, the leave policy at the board has been that you have to work 48 weeks for 5 years. The other 4 weeks are not called vacation. We call them non-clinical time. Some hospitals, I was surprised to learn, actually only give 3 weeks of vacation. Most of them give 4, but whatever the time that you're using that's not taking care of patients is considered non-clinical time. And in general, barring any extended leaves, you're supposed to work 48 of those a year. For 20 years, we had an additional 2 weeks off that was medical leave, and maternity leave, and I'll be specific about that, was housed under medical leave. We didn't call it out. It's just that if you gave birth to a baby, that was considered a medical condition, and you could access the extra 2 weeks, which could happen twice during your residency. So non-birthing parents, adopting parents, fostering parents, dads in the category of non-birthing parents could not access this. It was strictly medical leave, and that endured until about 3 years ago. I was on the task force for the ABMS, and they took a look at all of the specialties and leaves across the board as this became a ever more urgent topic, or a more vocal topic, thanks to, in part, to a lot of you, current trainees, Erica Rangel, papers that people were publishing, the studies that were cited in the earlier presentation. And it's funny because the ABS policies were actually cited as an exemplar, as sort of the best policies, certainly among surgeons. And that was because we allowed averaging so you could accrue time, and because we allowed, we had a large portfolio of extended time. So you could take as much time as you needed, but you had to make it up. So the policy, the important part about the ABMS parental leave policy is that it guaranteed 6 weeks of leave, including your vacation time, to anyone at least once during their residency. We felt that we met that. We didn't change our policies to update it to meet that because we thought we were already there. And about 2 years ago, we changed our leave. We left it at that additional 2 weeks, but we made it more inclusive. So it wasn't just the birthing parent, it was non-birthing parents, and it was really for any first degree relative. If you needed to take care of your mom or dad, if you needed to take care of your kid, if you needed to take care of your spouse, you could access the additional 2 weeks twice during your training. So we thought that we were in great shape. And we thought that the extended leave policies really covered things. And I do think that there's still something that you should take into account. Nevertheless, y'all didn't think so. So we heard pretty clearly that the existing leave policies, that the averaging didn't work that well, because what if you were chief resident, you hadn't accrued any vacation time, you already had a fellowship, so you didn't want to extend training, et cetera. Just felt that we were a little short of the goal, but remembering that we don't have competency-based metrics in place right now, we're still working on time. But with a lot of stakeholder interviews, talking to program directors, talking to trainees, one thing that became apparent is that adding those extra 10 days, 2 weeks, 4 weeks on at the end of your training was sort of dysfunctional. A lot of programs couldn't really do it, hadn't really planned for it. So we were living in a world that wasn't that valid. So we hit what we think is a compromise, which was making, instead of 2 weeks, make it an additional 4 weeks off, so that you can take a total of 8 weeks as parental leave, whether you're the birthing parent or the non-birthing parent. And that's actually true for all those other family situations we talked about. That's just came into place this year. It's retroactive to July 1st. And we think that along with taking advantage of extended leave, will cover what's needed for now until we can get competency-based advancement in place. I do want to take a second and talk about extended leave, because I think that 8 weeks is not enough if you have a new baby. It certainly is not enough for the following year. It might be enough time to stay home, maybe, but your kid's going to get sick. You're going to get sick. You're going to get stressed and depressed. You're going to need a family vacation. You're going to need time off. So I hate the idea that people are going to use their entire volume of time off in one block. And of course you would, because you'd want to stay home as long as you could. And I really ask people to consider extending their training, which is very parallel to what happens in academics across the board. If you're on a promotion timeline and you have a major life event, you get an extra year. If you're in college and you miss a couple of weeks off from school, that semester doesn't count. You have to make it up on the other end. So as difficult a pill as it is to swallow, we do have a lot of options. We were part of the reason that residencies, that fellowships moved the training start date until August 1st, so that there was at least a little bit of wiggle room where you wouldn't actually miss the beginning of your fellowship if you needed to take an extra couple of weeks off. So you can extend your chief year even into August if you're able to do that and still take your exams, keep your certification timeline intact. And we do have what's called a 5 and 6 policy, which can be used for parental leave. You can take as many months as you want off. You can take a couple months off and then another one later. You can take up to 12 months off, scattered over the last couple of years of your training in order to accommodate really anything. It's not just parental leave. It's if you have a special interest, an illness, you want to go climb Mount Everest. We don't actually look under the hood for what that's used for. We really want to make these things work for people. It's always worth getting in touch with us to see what can be accommodated. When the policy first came out, it says, if the program can accommodate it, and there was a lot of pushback around that. We have no power over programs. We only have power over your education. But happily, we work hand in glove with the ACGME, who had a task force at the same time as the ABMS, and we had a joint meeting, and they just came out with their statement about 3 weeks ago. And so effective July 1st, all programs, it's a program requirement, are required to have 6 weeks of parental leave that are fully paid, fully benefit, 100% of salary, includes caregiver leave, and then they have to allow for at least one additional week off, which means that most programs should be able to meet our requirements as well. And this is a lot more powerful really than our requirement, because everyone has to do it. If you want a residency training program, you've got to be able to have that, whereas ours is sort of an allowance. Theirs is a requirement. Everybody else had cute pictures on their intro. These are my kids. I had 2 sets of twins. They were all born after I finished my training. I was pregnant at the end of my chief year. For my first set, I was at a hospital that already in 1993 had very clear maternity leave policies, 8 weeks off, fully paid. You could get an extra month if your obstetrician said you needed it. I said, I have twins, I'm never having any more children. I would like that extra month. They gave it to me. And then I went ahead and had another set of twins by accident. And I was at Penn where they had no such policy, and that was quite an uglier story. But that's the board policies and a little bit of my own personal story. And I will stop sharing my screen now.
Thank you for the update and your valuable time, Dr. Buyske. Next, we have Dr. Dultz, who will present a call to action.
Okay, can everybody see that okay? Okay. Wow, that's hard to follow. But thank you so much, Dr. Dhillon, and thank you so much, Dr. Buyske, for giving us that update and just for all that you're doing and all the work that the ABS is doing and trying to move the needle forward on this important topic. We really do appreciate it. And so as part of this new policy, I want to transition now to what do we as trauma surgeons, what can we as trauma surgeons do to continue to create solutions for this issue of parental leave, safe pregnancy, et cetera. And these are some of the pictures of why this issue is so important to me. And I put up pictures, when I was thinking about this, I thought, this is my personal family, but this is also my trauma family. And they're both important to me. And, I'm selfish. I don't want to give either one of them up. And so this is kind of a personal thing for me to, why I care so much about the topic. I just care about both of them. And so for the next couple of slides, I want to just give you kind of some tips, some solutions to encourage you to become a part of this call to action and what you can do at your own institution to try and improve the culture and okay. So full disclosure, I will show you a few stats, but most of the ideas on how to move the needle forward on pregnancy and parental leave are just ideas and opinions. I definitely cannot cover everything in 15 minutes. So please feel free to email me if you want to talk more about this topic afterwards. And I'll talk a little bit more, but I certainly cannot take credit for all of the ideas that I'm going to present to you. I'll go furthermore into detail on that on a few slides. Okay, so the first question I think you have to ask yourself is, what can I do as an individual to push this agenda forward? And so if this is something you're passionate about, I recommend that you do the research, know the data, make this a priority for your institution. Set up a meeting with your senior leadership. Use the information that Drs. Dumas, Dr. Guidry, Dr. Buyske showed all just now to define the problem for them and why this isn't a problem that's going away, that you really you need to start getting on board and figuring out how we're going to make this work for our institution. You need the buy-in from leadership. Your leadership is one of your most important stakeholders, and it's key to getting things done. So get their buy-in, get it early. Once you've done this, make a proposal to create a family planning task force at your institution. And similar to like what Dr. Buyske was saying about the ABS creating a parental leave task force, make your own family planning task force at your institution, parental leave task force. This is where you're going to create your agenda and get things accomplished. And, look, at the end of the day, if this is too much and you just don't have the bandwidth to add on another project, because I completely understand, you just have to simply agree to acknowledge that this is a problem and to support this initiative and be part of this positive change. And so this is what we did at our institution. We identified the problem, we got buy-in from our leadership, and we created a family planning task force. And so these are some of the members, and it consists of faculty, residents, admins. This is the chair of our task force, whose picture is right below the title, Dr. Chiaka Akarichi. And she's a burn and critical care surgeon. And so she's led our group to do some great work so far. And some of the ideas that I wanted to present here are ideas that, she's led our group and our group has come up with. And so we created an agenda, and ours encompassed several other topics related to family planning. But for the purpose of this talk, I'm going to talk about the 3 initiatives that we're working on. And so the first one, providing an environment for residents and faculty to maintain healthy pregnancies that are safe for babies and mom. Number two, we're working on options to allow for paid parental leave, not only for residents, but for faculty also. And then number three, just changing the culture, which is always the hardest to do and will obviously take the longest time. And so the first thing I'll touch on are things we've been working on to improve our work environment for pregnant physicians. And this is residents, but we're also doing some things to improve the environment for pregnant faculty as well. And so these are some of the things that we're working on, and I'm going to go through them in a little more detail. And so several of our residents have created this amazing handbook for us. And basically it's a resource. It includes a list of OBs, pediatricians, childcare options, FMLA policies, where all the lactation spaces in each of our hospitals are. And so what we're doing is we're making this available to our department so people have a more transparent view of where the resources are, of what the resources are and what's available to them if they want to start having a family. And so if you're doing this at your institution, the key is to find the information and just make it accessible, just make it easy for people to see. So it's there. And as an aside, I love to highlight this article. This article is called The Pregnant Surgeon. You can easily look it up in PubMed. It's by Drs. Harnsberger and Davids, who are colorectal surgeons. It's a great guide to practical recommendations for pregnant surgeons during each trimester. And it gives, it's a great reference for those that are interested in. I like to share it with people. Some of the things, that's highlighted: in a pinch, you can use a hemostat to clamp the pants, your pants to the top, preventing an embarrassing drop of the pants while scrubbed, when you're in your third trimester and your pants are constantly falling down. Or they remind you to say, okay, if my resident is pregnant and they have lifting restrictions, should they be actually retracting, for hours on end on a certain case? I think these are things that we forget. If it's not us going through them, and we have to always be mindful and empathetic of the other person across the table from us, and realize, are there physical restrictions that they just can't do at this point in their pregnancy? Another thing we're doing is creating a faculty advocate for our pregnant residents. And this is really to make sure that the residents know their rights and are given a copy of our handbook. We're also going to look at their rotation schedule and figure out which rotations are better fit for whatever trimester of pregnancy they're in. So ideally, you're not going to be doing 24-hour trauma call when you're 37 weeks pregnant. Or look, if you're at a smaller institution and you can't, make those, you don't have enough residents to go around, then at least making sure that there's dedicated rest time built into those calls so that the residents are not feeling discriminated against if they're starting to have contractions and they just can't get through that 24-hour call, because there's clear evidence that shows that, that there's a higher risk of preterm labor by doing 24-hour calls after 35 weeks. And so this idea stems, so what we're doing is we're making sure that the residents are protected, and we're taking the residents out of this decision-making process. So a lot of programs, I know, they ask the residents to just come up with their own solutions, to switch rotations with each other, just to cross cover each other. And as was mentioned before, I think this can breed resentment. And Dr. Dumas and Guidry had pointed this out in a survey. This can breed resentment. This has a negative behavior amongst residents. And it's then challenging to be pregnant during training. And so by having this come from our leadership and our faculty, we're stating that this is a priority. Everybody's going to get the same treatment, and we're not asking other residents basically to just, quote unquote, pick up the slack. We're actually making policies on where these residents are going to go, and not asking other residents to cover. And so similarly, we're advocating for a policy that no pregnant resident should take a 24-hour call after 35 weeks, because as I had mentioned, there's clear evidence that shows this increases the risk of preterm labor in our specialty. We're also creating a sick pool, and it's going to be composed of residents and APPs, so that if a resident does need to take time off during pregnancy or after, or if they need to take their 2-month-old to, their pediatrician appointment to get their vaccines, that there is a dedicated pool of residents every month that their only job is basically to provide cross cover to cover those residents that need time off. And that's not only going to, be for parental leave, maternity leave, that's, really going to be used as a global sick policy. So residents don't have to come into work if they have, a fever or they're vomiting or, whatever it is. And so I really think that this is important. And again, if you don't have enough residents in your program, then this is a great way for you to go to your institution and your hospital and to say, hey, maybe we need to hire some APPs on this, because again, these policies are coming. We're going to need to be prepared. And so we need to hire more people in order to help. And so those are some of the things that you can work on at your institution during the pregnancy phase. But so now what about paid parental leave? So why is it important? We've kind of talked about this already, but when you're talking to your institution and your employer, things that you want to highlight, and these are all things that have been studied and are just, and these are facts. It increases employee retention. It increases employee loyalty. There's long-term savings for the institution because you don't have employee turnover and loss, and you decrease the cost of recruitment and training. It increases diversity by keeping women in the workplace. And then for dads, the studies are now showing that fathers who take paternal leave are more involved with childcare responsibilities, which was shown earlier. And they report higher satisfaction with parenting. It improves the home life. It improves the quality of childcare that's needed when both parents are working. And it also improves child health outcomes by allowing parents to take time to take their children to the doctors if they're ill. So all of these things are things that you can specifically write down and say, this is why this matters. And so what can you as the individual do? So, Doctors Dumas and Guidry explained, we're in a really critical time right now in our nation in potentially getting the first, national paid parental leave policy through. Right now, the Build Back America plan, it was started at 12. It was supposed to be 12 weeks. It's gone down to 4, but it's still on the table. Many people are still debating it. And so if this is an issue that's important to you, I want you to, you can just take 3 minutes of your time and go to this website. It's Parental Leave Plus US. And so this is the largest parental leave organization in the US that's lobbying for paid parental leave. All you have to do is go to the website. You click email your members of Congress. You put your name, email, state. It generates a pre-populated email urging officials to keep paid parental leave on the table. That's all it is, really. And it's being your own advocate. And so if this is something that's important to you, take 3 minutes and just do it. Also, so if you are lucky enough to be in one of the states listed here, so these are the states that have already passed legislation to cover some form of parental leave. So if you're in one of these states, go to your state website, find out the details, know the options, so you're prepared when you need to take time off. And then, go to your institution's website, find out what's available. So about 50% of top US medical schools right now have some form of paid parental leave for residents. Go find out what you have. And if you don't have anything, that's your first agenda item for your family planning task force, and you're going to work to change it. And then lastly, I'm going to leave you here for the paid leave. These are options that you can use in order to try to pay for your parental leave, both as a resident and a faculty member. And I think this is really important from the resident standpoint of what Dr. Buyske was saying with the ACGME leave policies that are coming, that programs have to figure out ways to fund this. And so the first one here, which is highlighted in orange, is short-term disability. And so this is a really well-kept secret that women do not know about and don't use enough. And that's from the resident level and also the faculty level. Most hospitals offer some form of disability for both the residents and the faculty. Most hospitals, you're automatically enrolled in some policy, but you have an option to upgrade to a higher one if you need to. And most of these policies will cover maternity leave in some form or another, but you have to look at the individual policies. So now, for the programs that are trying to figure out how do we pay for this, like this is part of the option, because most of the time they don't pay, short-term disability doesn't pay for everything, but they do pay for some, potentially up to 60% with a cap. And so talk to your institution about what the coverage policy is, get the information, disseminate it to your residents, disseminate it to your faculty. Your interns coming in, if they are interested in having a family during, residency training, then this is probably something that they need to look into, and they need to look into it early. Other options that we're looking into, at least, are asking your university to set up endowments, raise donations. We've clearly identified that this is a problem in our community. And, we have higher risks of preterm labor, et cetera, and miscarriages. And so, set up a fundraiser, see if your institution can set up a trust, use the money for paid parental leave. You can look into shared sick leave between colleagues if you're faculty. We do have this at my institution. So partners can actually donate sick time to others. And this is really nice so that, again, if you've run out of your vacation or sick time, that, if your partner wants to donate, or if you have a pool of sick leave, that you can pull from that. And then lastly, in blue, recouping malpractice premiums. I wanted to point this out because I think it highlights the need to just be creative in some ways. So the OB department at Brown published that they were able to create a paid parental leave for their faculty by recouping malpractice premiums while they were out on leave. And so, they recognized that the institution needed a cost-saving policy, and they identified a cost-saving way to, obtain parental leave for their faculty. So I think that this was great, and I think it highlights just how to be creative. And so last thing I'll talk about, and then I'm done, is culture. You can talk all day about it, I think, but it's, really complex. And what I think, simply needs to be said here is that there needs to be a cultural shift, and it needs to start from the top, like Dr. Buyske. So thank you again for being here. I think, the leaders in our departments, have to buy into this. They have to practice what they preach. Otherwise, it's going to be a setup for failure. And this is, the part where if you don't want to do all the other things that I just talked about, I think the main thing is just support the cause. And just, if people are talking about it, just buy into it. And, you don't want to be that faculty member that is, kind of rolling your eyes if a pregnant resident has to take a bathroom break or is having a hard time if they're returning to work. Maybe they're sleep deprived, maybe they have postpartum depression and you just don't know it. I think, we each have to remember to practice compassion and empathy, not only for our patients, but for our trainees and our fellow colleagues, and just, realize that we're all human and we all need a little bit of time. And then, so that's really it. Those are, some tips that I hope I can help you guys with. Final thoughts are just, be proactive, be creative, lead by example. Again, just, a lot of these ideas were from our family planning task force, which Dr. Akarichi leads, and she's wonderful. And so if you wanted more information on some of these things, I just put my email and Twitter. And then, I'm part of the associate members of WST. We have a WhatsApp group. So please feel free to join if you're an associate member, and we can send you some more of this information. So I got.
Thank you, Dr. Dultz. We now have our panelists who will recount their experiences of parental leave, either during training or as a junior attending. We will begin with Dr. Coleman. Julia had Norman actually earlier this year at the end of her 4th year when she was a chief resident on a busy trauma service at the University of Colorado. And he is now 10 months old. So Julia.
Thank you, everyone. It's such a privilege to be a part of this panel. I think it's such an important issue, and very much appreciative of everyone that's spoken so far. I'm a chief resident at University of Colorado in Denver, going to Ohio State as mentioned for fellowship. I was a 4th year chief of trauma when I was pregnant, and then had my son. I took 6 weeks of maternity leave, which at my institution at the time, how that was structured, it was all of my educational leave, sick leave, and vacation leave combined for the year. So I did not take any vacation time or ed leave and combined it all for my maternity leave. And then I came back and did breastfeeding and pumping for several months once I came back as well. So that's my experience, and I'm happy to talk more about it. And my 10-month-old took his first steps last night. So it's an exciting time.
Thank you, Dr. Coleman. Next, we have Dr. Bankhead. So Brittany had 2 children. She had her first as a 3rd-year medical student and one as a PGY4. Brittany?
Hey, yeah, so apologies for the large dog in the background. Yeah, so I guess kind of briefly, my experience in residency does not go too far from what a lot of us have talked about offline with health problems. And I remember I had a TB scare really early on. Even before I found out I was pregnant, I had been exposed to TB. And so then that was how I spent my first trimester, was dealing with the health department. And then I had the flu. I broke my foot trying to rush to a melanoma case one morning. And I still took Abside the next day at in my 3rd trimester. And certainly remember what Dr. Dultz was saying about all those operating things, putting your belly on the operating table, trying to reach those deep spaces, even when you really can't physically reach them. But then I think maybe something we haven't talked about here at all today and lends itself to another time is our trainees, our medical students who are pregnant and what they go through. And I think the biggest things for me in thinking about that and how that was a little bit different from being a resident is that on the plus side, I didn't have anyone to cover for me. It didn't matter if I wasn't there. So from a leave standpoint, that was a little bit better. But the biggest thing was that I had absolutely no rights and I had no one to really advocate for me. So at prenatal appointments, I really didn't ask all the questions I wanted to because I'd been on my rotation earlier and I was afraid that if I asked a question that that would be seen as being dumb about OB-GYN and I should really, know the answers to those questions. And then in a hospital, there's a picture from the day I delivered my son and there's like 20 people in this room. There really need to be 20 people at the place where I did my OB-GYN rotation in the room where I'm delivering. Probably not. But I was afraid to speak up. I didn't want to say anything as a student. I felt like that was not my place. And then on maternity leave, I really only took 4 weeks before I came back. I was very sleep deprived, but I had to study for step 1. And so that was really tough. So I think the biggest thing for your medical students, if you have any of them that are pregnant, is to really provide a safe space for them to ask what they want to and ask them what's important to them, and to be an advocate for them, which I think is universal across the board, but especially for our students.
Thank you, Dr. Bankhead. Our next panelist is Dr. Strickland. Matt is a trauma and general surgeon working in Edmonton, Alberta, Canada, and the father of 21-month-old Remy, and in January, a new baby girl. Matt?
Yeah, thanks, Dr. Dhillon. Thanks for the opportunity. I feel a little bit like I'm the token Canadian, like to add a little bit of international perspective on this. And I think it is something that I can bring. Although I did most of my training in Canada, I lived in the US for probably 5 years total between grad school and fellowship. And we had our son when I was rounding the last 6 months of a 2-year fellowship in Los Angeles. And, one of the really which I hope can add a bit of perspective, one of the interesting learnings was just how much of a mismatch there was between our expectations as Canadians with what maternity leave and paternity leave look like to what was the norm in the US. And, Ryan, Dr. Dumas showed that chart of the world in Canada is like a dark blue on all of them, meaning that there's a lot of paid social support for maternity leave. And so, when we found out I was going to have a kid, I started looking at what it was going to look like to take some time off. And my wife was also working as a physician at the time, and she was livid. I cannot overexpress how angry she was at the thought that she would have to take only 3 months off to go back to work. And that's because the average in Canada is 9 to 12 months. And that's, even if you're a professional, even if you're a physician, that's certainly the norm would be to take that much time off. And our trainees most of them, I don't think I've heard of anyone not extending their training, because usually the norm is to extend your training so you can take that very regular 9 months off. And so, part of a lot of people look at as well in Canada, there's paid paternal leave or parental leave, I should say, for up to 18 months. And where I think that's most important isn't in the way we think of it, because as physicians fundamentally, especially as attendings, we're relatively well paid. It's not the money that we need, but that 18 months, that 9 month average sets a societal expectation for what it looks like to take time off to start your family. And I think that's its real value, is that if we don't, expect that to be the norm for minimum wage workers, for service workers, for white collar workers, why would we expect it out of physicians? And so it's something that I think is important for that reason. The other barrier we hit up against when I was getting ready to take to have our first child was the same things everyone else has mentioned, which is this medical, the inflexibility of medical training. And I think that at the end of the day, that sort of trumps a lot of things. And what's powerful about that is that that's the thing that we as a group have the most power over. That's what we can start directly affecting change on when we go back to our own institutions. To think that any one of us is going to change nationwide social support systems is a little overly ambitious, but we can certainly start doing the things that Linda talked about at our local institutions. And, I think that's very powerful. As as my last little thought, so what am I going to do now that I'm having a kid in Canada, right? Am I going to do things differently? And that's where rubber meets the road. And it's really hard because I don't want to leave my partners in a lurch. I don't want to put things on hold and so on. And so in a way, I feel like I remain part of a problem by not taking time off. And so I think, much to my wife's urging, and honestly, from conversations like these, I think part of being a good ally is taking that time off and trying to role model what it looks like to be a good parent and a good leader who embraces this sort of new change in the profession. So I'll leave it at that.
Thank you for being our token Canadian, Matt. Last but not least, we have Dr. Duma. Ryan is the father to his almost 3-year-old daughter, Anya. She will become a big sister in January after the birth of her baby brother early in the new year. Ryan?
Yeah, this has been a really interesting and really great discussion, and I appreciate everybody's thoughts and insights. For me, I had Anya when I was an attending, and so my perspective maybe is a little bit more that of like a navigating the bureaucracy, I suppose, for lack of a better term, of an institution that really has, as Dr. Dultz pointed out at UT Southwestern, they've made a lot of really great changes. But for me, it's still, and for my wife in particular too, it was a black box. Like, we didn't really know. I remember it was Samir who called me, and like the day before, my wife's going on maternity leave, to say, "Oh, you can donate your sick time." And so that's how, and so my wife's also a physician and she's at the same institution. So not only is FMLA, if I wanted to take a paternity leave, then I would be chipping away from her maternity leave, because the 12 weeks is amongst both employees. So there was so that goes to Matt's point. Like, I didn't even, if I wanted to take a full paternity leave, I couldn't, or I would be taking away from my wife. And so, but then through really colleagues, which is kind of what that first survey pointed out, is that right now the current flow of information is between colleagues or trainees and residents or between fellow and fellow. So there's got to be a better way to disseminate that information, really, I think, which I think points a lot of what Linda, Dr. Dultz talked about with, there's some action items. And so for me, it's like I found out last minute that I could donate all my sick time that I had accrued to my wife. And then but still only then, because we were new employees, we hadn't accrued enough time, vacation time and sick time, to get a fully paid leave. And so I really encourage everybody to realize what's out there. And that also kind of dovetails into the short-term disability piece, which I think is, we only found out at a benefits stand by a very, very helpful benefits rep during the enrollment period. And I think Dr. Tatabi's point is an excellent one in the chat. It's a game, right? Because if you pay for your short-term disability too soon, knowing that you're going to get pregnant, then it's not worth it on the back end, because you paid into a system and you only get a few months. So what you need to do is you need to kind of plan for your pregnancy and ideally as much as we can, and then sign up for short-term disability right before, essentially, right? And then you get the benefits. So for us, it worked out well because my wife was due a few months after starting our jobs, and so we had only paid a few months into short-term disability, and we got the full disability, and so it ended up, helping substantially. So those are the kinds of things that I think I learned and we learned on the fly, really. So I would encourage you guys to really talk to the benefits people, and the benefit, you can't just go, at least here at UT, the benefits period only opens once a year. But that's the time that you really need to reassess that and make changes to those kinds of policies, because there's small things that can really ultimately make that transition and that of maternity leave and paternity leave easier.
Thank you so much to our panelists. Now we have some time for Q&A. There's a question that was asked by Dr. Rebecca Schroll, and I know that Dr. Buyske had answered it, but I think it'd be great for the audience to hear. So the question is, since one of the barriers to residents extending training is that some fellowships still start July 1st, is the ABS working to help convince the remaining fellowships to move their start dates to August 1st?
So getting the fellowships to do that was more of a diplomacy event than a control event. There was just a lot of, we know this is the right thing to do. It's ridiculous to have people finishing their training on June 30th and starting somewhere else on July 1st. We weren't even addressing parental leave. We were just addressing reality. You can't expect people to do that. People were leaving programs earlier. They were having to decide whether to screw their old program or their new one. It was ridiculous, and it wasn't fact-based in any way. So we used the one power tool we had, which was to move the qualifying exam into July and say, do you want them to spend the first 2 weeks of their fellowship studying, or would you like to start August 1st and have that out of the way? We also had the advantage that orthopedic surgery has been doing it for 20 years, 25 years now. And so when they said it's not possible, how can this happen? We were like, I don't know, ask the orthopedic surgeons. But it's a local event, and the DIO and the onboarding and stuff all has to agree. So it's a little bit of a groundswell. So the ACGME is really, really interested in this stuff now. They do have control over programs. We can only use carrots. But writing letters to them is a way to go. We do still bring it up. I just brought up with vascular surgery. I was like, please tell me how many of your fellowships are still starting on July 1st. So yes, the short answer is we will still keep pushing, but we've shot our big gun. So y'all need to help with that a little bit too.
Thank you so much. So again, if you have any questions, please go ahead and enter them in the Q&A function on Zoom. Just a question to the panel, and if anyone wants to pitch in for this. I've been talking to some of my friends, and I think one of the things that people are looking at when they're looking at their first jobs is a little bit of transparency about how whatever institution or department that they're joining would be supportive of, taking time away. What's the best way to gauge that into a new program where everyone kind of shows their best face?
Well, I'm not part of the panel, but I can tell you, I'm sorry, I'm gonna just, I give really quickly though. I think looking at the faculty themselves and looking at the diversity and their personal lives, right? Like if you have a diverse, and that goes for anything. I think anywhere you go that has a diverse faculty, tons of different experiences, exposures, perspectives, whatnot, shows that you have that you're potentially joining a place that is open to various opinions and thoughts and change. And so I think just look at the diversity of the faculty. But I don't know if you guys have anything else.
So
I saw you reaching for the mic, Linda, so I knew that's what you were going to say something. But I agree. Like if during your interview phase, when you're meeting with everyone, you can get the impression that your division head's taken a period of parental leave, that this is what the culture does, and it's hard to ask directly. But hopefully, by making small chat around life events and who's who and who's who has kids and so on, you can find out that sort of thing. I certainly got the impression before moving here that our division head had taken 9 months off, that most of the surgeons here take it very seriously.
So I think if you're having this as a society meeting, right? So you're trying to take the burden off of the individual and make it a society-wide event. It's hard for the vulnerable person. It's hard to show up pregnant and then, ask what parental leave is. It's hard really, even as a woman, to ask what parental leave is. So you can practice asking without turning red or stammering. You can practice saying, tell me about these 5 different aspects of the program and put parental leave in. And I would suggest that you can also get all of you to agree, men, women, people past childbearing age, people who aren't interested, to say, this is one of the questions I'm going to ask as a routine, always. And kind of march forward like a big, phalanx. So, use allies, and, allies are, it's always ideal to have allies who don't have a very personal dog in the game. And so very useful allies are people who aren't planning on having children or have already had their kids. And the other really useful ally group is older surgeons who have kids who are surgeons. That's like a super eye opener. They're great allies, she says slightly bitterly.
Our next question is from Amy Murphy. Any advice for small residency programs when 1 or 2 residents are on parental leave and that turns into other residents being spread very thin to cover?
I mean, I'd say this is a big issue, and it sort of comes back to what the service to education model is at your program, and like how equipped you are to handle disturbances in your human resource model. And so, I think programs should aim to have a really robust model. In Canada, a lot of the general surgery programs have had to contract their numbers because we were overtraining not just general surgeon, orthopedic surgeons, and so on. And because of that, now the programs have to look to fill those gaps with nurse practitioners or physician assistants. But in the service to education model, you probably can never make it purely educational, but the goal is to make it so that you could lose the resident and the show would go on, right? And so it's a hard thing to do fiscally, but it's about making systems that are robust to disturbances, I think.
I think that's so true. And I think that goes back to Dr. Dultz's whole spiel on a call to action and a task force. And that is something tangible that everyone needs to be doing. Even, like you're saying, Matt, that even was applicable in COVID times, right? Like we had to have, it was a new thing. We had to have backups and backups and backups. And like the list went on and we realized it was a really big problem. And so we created task forces to deal with those. And when people were going out sick, and that was a new thing. So this is not unlike that. And I think making these task forces so it can be an institutional specific thing and your residency specific thing is really important.
I think this is just an opportunity for attendings to lead from the front too, right? I think we rely on our residents so much to a fault, myself included, right? I was on call last night and I can't function without them, but and they're fantastic. And so, but it also means that like, if I have a resident that's out sick and our float residents are busy, like I can write an H&P, I can scrub a case, I can, and so that's really an opportunity for us that I think that, and that's the whole, and that's something I think if we do, and again, this is a bit of a pie in the sky, but like Dr. Buyske was saying, if we do it, kind of, as a group, as young junior faculty and trainees, that's a mentality I think that we should become more comfortable with.
Wonderful. I'm going to quickly share my screen really quickly.
It's really tough. Oh man, you pulled it off really quickly. Nice work.
So we're going to be ending our grand rounds here. I just want to mention that there will be an accompanying discussion on AAST Connect where you can participate offline. And here's going to be the QR code so that we can continue these discussions. And if there's any resources you'd like to share, there's a function to upload those resources there. And with that, thank you for attending today's grand rounds. I'd like to remind you to please turn in your sign-in sheets to the AAST office by this Friday, November 19th. Join us for our next grand rounds on December 15th. Thank you and have a great night or evening.
Thank you.